Okay. We're going to give it one more minute for a 12:30 start. Thank you for joining those people who've joined us so far. Okay. So thank you everybody for joining us for this first of our webinars on recognising and responding to deterioration in a person's mental state. As we begin, I would like to acknowledge the traditional owners of the land on which the Commission is based, the Gadigal people of the Eora Nation. We pay our respects to their traditional owners, to the elders past and present, and to emerging leaders. We also pay our respects to any Aboriginal or Torres Strait Islander people who may join us today. The Commission also acknowledges the lived experience of people with mental illness and their families and carers. And I can say from our point of view, the determined leadership of mental health consumers and carers has resulted in improvements to health and safety for all health consumers. So, housekeeping. This is a webinar, so there will be some capacity to take questions, hopefully, with the timing. And if you have questions, everybody's muted, but you can put them into the chat, which is on the right-hand side of your screen. We'll be monitoring that chat. We'll take questions at the end, if we have time, so that people have opportunity to give their full presentations. The webinars will be recorded, and a link will be sent to all people who've registered, and they will also be put on the Commission's YouTube channel once they've been captioned. If after the two sessions you still have questions, our email is here and you can get in touch with us. You can get in touch with us at any time. So a quick overview of what we're going to be doing across the two sessions. We're going to be hearing from consumer and carer representatives about what these processes mean for them from a lived experience point of view. That's going to be next week. We're going to hear from clinicians about some innovative approaches that they're currently taking and they're still evaluating. And we're going to hear from quality managers about how they oversee the processes and develop evidence for the overall quality improvement related to this. So back to where it began, recognising and responding to deterioration in a person's mental state is built on effective processes for recognising and responding to physiological deterioration. And this was the slippery slope that was described for physical deterioration. Before these processes were brought in across hospitals, there was a lot of evidence that people were having, adverse events like cardiac arrests and respiratory arrests, that when they looked back, you could have seen that the early signs were there and that weren't picked up. And these systems had resulted in huge improvements in the rates of adverse events for people. It feels like a no-brainer. If deterioration is picked up early, then the interventions that you're going to have to use are going to be less intrusive, and the likelihood of a good outcome is going to be better. As you proceed down the slippery slope, the chance that there will be harms, that outcomes will be harmful for the person, start to increase. Equally, the interventions increase in intensity. So some of those harms can be the distress related to deterioration in mental state itself. It can be related to actions that people take in response to that distress. It can be related to the actions that other people, including clinicians, take. And so that could include the use of restrictive practices. So effective recognition and intervention will also reduce the use of restrictive practices, which is a huge goal for people across health services and particularly in mental health. So How does the model translate to mental health? Obviously, some of the language used there is not language we would use in contemporary mental health discourse. And I think people who work in physical deterioration might roll their eyes at this, but there are somewhat standardized parameters for physical functioning. So if your heart rate continues to increase, and this can be tracked, you'll probably end up having a cardiac arrest. It's not so straightforward for deterioration in a person's mental state. One of the pillars of the effective physical processes was the use of observation charts and the development of sort of automated standardized track and trigger processes. So different color bars and adding up scores that enable people to follow a stepped and preset escalation pathway. Again, this is not so straightforward in mental health. There has been long-standing wish for an observation chart that's going to solve all of these problems. And I have to report, the Commission has been looking for years, both in Australia and internationally. No chart that's fit for purpose across all health settings and for all mental health conditions has yet come to our attention. That's not to say that one day one won't come, but a chart is not what's going to solve this issue. So we need to look elsewhere at what the solutions are. One of the key issues is, and we put this into all of our language, is it's deterioration in a person's mental state. So it's happening to a person. It's not some abstract thing that can be checked and marked on a chart. So another huge aspect of early response and effective intervention is greater opportunity for working with the person themselves and with their families and carers. So supported decision-making, shared decision-making to minimise the risks, but also engage the person's own skills and capabilities in resolving the deterioration. They're also, along with being person-centred, there are other aspects of person-centred care. It should be recovery-oriented. So when a person might experience a deterioration in mental state and risk processes kick in and autonomy and agency is taken away from the person, this can affect their long-term recovery. It can be very traumatising. It can also trigger previous trauma. So person-centred care needs to take into account all of these things. Also needs to take into account cultural competence, cultural sensitivity, because people will have different ways of expressing deterioration and distress. So that's not to say, of course, that risk is not a major part of what can happen with deterioration in a person's mental state, but it's not the whole thing, and processes should not be based just around risk assessment and risk management. So, second edition of the National Safety Quality Health Service Standards contained actions related to recognising and responding to deterioration in a person's mental state. And these actions call for health services to have processes in place. There are also actions in the National Safety and Quality Digital Mental Health Standards that were released in 2020. So the Commission has been working over the years with stakeholders to develop supporting resources so that these actions don't come out of the blue. In 2014, a team led by Leonie Craze did a scoping review, and they concluded that while there was no direct evidence of systems in place for recognising and responding, transposing that model to mental health, there was definitely interest in applications of the model and a lot of things in place that align to this model. So then we worked with stakeholders and released the National Consensus Statement, which contains both essential elements, so practical things that a service can put in place, but also the underpinning principles of the approach. and I've talked about those briefly: person-centeredness, trauma-informed, recovery-oriented, culturally competent. In 2018, Gaskin Research undertook a project on behalf of the Commission to try to develop shared language around the signs of deterioration in a person's mental state that consumers and carers can use, that clinicians with or without mental health expertise can use. And so they did a modified Delphi process with a group made up half of consumers and carers and half of clinicians and academics and quality managers to describe signs, to whittle them down, and they then produced a series of sign clusters. And those sign clusters, you'll notice the first thing is reported change. So the first thing in looking at recognising deterioration in a person's mental state is what the person themselves is saying and what family members, what carers might also be saying. Does your system give that prominence? Does it give it weight in the recognition and subsequent response? Then there are the other clusters that people can notice externally. So distress, loss of touch with reality, loss of function, and risk. Now, these have proved quite popular. We would have to say they haven't been sort of validated in a kind of really rigorous approach, but they're quite useful. They also align with other methods of arranging, other kinds of categories that people use. So the most recent piece of work we released to support services was the escalation mapping template, or the EMT, that came out last year. This is in a lovely Excel spreadsheet. And what this is a quality improvement tool for services to assess the efficacy of the systems that they have in place. And so there's some information about how to set up a process for review, who should be involved. And there are then a whole series of worksheets that look at the different aspects of what might be part of your system. That includes the workforce skills in your specific context. That includes any tools that you may use. That includes things like the direct escalation pathways for families and carers. Now, these slides, obviously, you know, we've put them up. You're not meant to necessarily be able to read them. They're just to show, the tool. And we have links to the resources, and I think we sent a link out with registration to this webinar. So I suppose what the EMT does is kind of summarise our current position. We still get calls for a kind of miracle chart that's going to solve problems. But increasingly, what we know is that a lot of services already have good processes in place. This didn't arise yesterday, but when the Commission started to talk about recognising and responding, people have been delivering this care for decades. And so what the use of this model and the actions and the standards are doing is just structuring the description of the local model. A health service, for instance, an emergency department, the people there, their job is to triage, to determine the acuity with which somebody needs to be seen and who they need to be seen by. They're very used to using the Australasian triage scale, which has mental health items, or the mental health triage tool. In mental health services, where clinicians are trained in mental health, they use the mental state examination or variations of it. That's embedded into their systems. Other services, for instance, general wards in large tertiary hospitals have frequently clinical liaison psychiatry teams, and they have referral forms that people can use that contain the information that that local service sees as good information for referral. What we understand is that people are used to these tools, and in many instances, they prove effective for supporting recognition, for setting out the steps of an escalation protocol. And so the Commission doesn't recommend that people necessarily go off and try to develop a new. We wouldn't discourage it because it's a fascinating part of how we do our work. And we could have an hours-long discussion about how tools and standardised tools can support clinical judgment. We don't have that time, but we just want to kind of direct people back to what are the current processes in your service. Tools are part of it, but a critical part of it as well is what is the culture? Is there a culture? So at a stark end, we hear from consumers and carers that there is still stigma and discrimination amongst health workers. And we know that health workers are people who live in the community like everybody else, and there is still stigma and discrimination around. It's reducing, but it still exists there. That's the stark end. But is the culture one that looks at holistic care, person-centred care? Are staff, if they pick up that somebody's not travelling well, able to pivot from a task that they might be doing and focus their attention for some time with the person on their mental state? Sometimes it's as simple as an empathic response, a recognition that a person's not travelling well, that can help the person to re-engage their own skills and manage the situation. Sometimes it's a simple intervention. We know that medication safety and medication reconciliation is a big part of people's care. And so if somebody's medication might have been ceased or interrupted and not recharted, they could start experiencing a deterioration that's very, very simply remedied by reinitiating the medication. And then there are the steps where a person recognises that the person's not travelling well, their own skills might not be competent to solve the situation. And so what then is the referral pathway? What is the local referral pathway to get specialist care? What is that pathway after hours? What is that pathway on weekends? Looking at these systems will help improve. And again, I just would reiterate, the Commission understands that this work is being done effectively. People don't need to panic about it. It would be very, very good if we have more capacity to share work. Unfortunately, health, and this is a big struggle for mental health in particular, a lot of interventions, it's very hard to describe in a kind of classic random controlled trial evidence base. And so things don't necessarily get written up in articles that people can then grab and adapt to their own systems. Another key thing that happens, and we've seen this a lot, is people get some way along with a process. This has included charts. We've seen charts where people use the categories described in the Gaskin report, and they set up charts that mirror an observation chart for physical deterioration with the colours, with intensity markers, and with escalation pathways described. In clinical practice, through piloting, some of these have not worked. And so, of course, one of the things that it's very difficult for us to track is knowledge that is gathered and then part of it is discarded. And then what happens is we see another team doing very similar work. So one of the issues with these webinars is to share some work that's in development that hasn't been published yet, and to share some of the thinking that people have engaged with. So I think that's enough from me. People who know me know I could talk for hours about this, but it's something that we're very passionate about at the Commission, and we've been immensely encouraged to see the great work that people are doing. And so these webinars are one way of sharing it, and we certainly would like to hear from people if they would like more of these webinars, if they would like information in different ways. get in touch with us through that email address and let us know what you'd like to hear about or see. So I'm now going to move on to our first presenters, Emily McGuigan and Jackie McCall, and they work in quality improvement at the Royal Children's Hospital in Melbourne, and they have presented to the Children's Healthcare Network their experience of using the escalation mapping template, the EMT. So thank you, Emily and Jackie.
Thanks, Andrew. We'll just get to our presentation. Can you see our screen?
We can see your screen.
You can see our screen. Oh, thanks, Andrew, for that introduction.
So hi, and thanks very much for having us to present our experience using the escalation mapping tool or template today. For us, this has been a process over years, from understanding the new national standards, engaging with the Commission, collaborating with the Children's Healthcare Australasia, and then applying the escalation mapping tool to understand our process gaps. This is an honest presentation where we disclose some of the process gaps relating to our adolescent medicine ward, Kelpie, and share our initial action plan and discuss the benefits of using the EMT. It has been a valuable exercise that has guided us to improve patient safety and support the wellbeing of our staff. For those of you that don't know, the Royal Children's is a 340-bed paediatric hospital in metropolitan Melbourne. Kelpie Ward is a 32-bed unit that delivers developmentally appropriate inpatient care and treatment to children and adolescents. It specialises in caring for patients admitted under the adolescent bed card, including the management of patients with eating disorders. It is estimated that 60% of our chronic illness patients have mental health problems. The Royal Children's also has a mental health ward. It's called Banksia. It's a 16-bed inpatient unit where young people aged 13 to 18 years are assessed and treated for a range of mental and psychological disorders. It's important to note that the mapping process was undertaken in November and December last year, and was a very challenging time during COVID, when all hospitals have seen an increase in mental health presentation to the emergency department. Internal data shows us that our adolescent ward is the third highest ward at RCH experiencing code greys, which is our escalation for aggression. On average, we have 28 code greys per month. Hence, our adolescent ward was chosen to trial the mapping tool to test the local processes in place and in line with the national standards. We had 4 one-hour sessions facilitated by Emily, Annie Molden, who's our medical lead for quality, and myself. We did aim to have a consumer, but had trouble getting this piece of work done in the time. Also, the acuity on the ward wasn't suitable at the time to choose an appropriate consumer. In future, we would consider a patient who'd been discharged following admission to interview. We know the lived experience of consumers are key to this piece of work. During these sessions, there was 2 of us facilitating. One of us focused on asking the participants the questions. The other person was scribing. The questions to consider, provided at the top of each page of the EMT, guided us to promote better discussion amongst the participants and allowed further insight into the problems. There are tick boxes on the EMT to also guide you, but we found this stagnated the conversation with reduced discussion. At the end of the 4 sessions, we summarised the information on the EMT and then distributed it back to the key stakeholders to assure that we had captured the information correctly and that it was an accurate reflection of what was said in the sessions. This slide outlines the topics that the EM team highlights for discussion. In this presentation, we will now share each component of the process, highlighting in red the problems we identified, and then map them against the standard to show the process gap, which is in yellow. I think what is really important to stress here, that there are many good things happening between the ward and the adolescent department. There is also a lot of respect between the teams we interviewed, but the purposes we were asked to highlight the problems and the leading onto the gaps using this tool.
The EMT provided us with questions to ask during the sessions, and the worksheet related to the workforce skill in responding to a person's mental state and the availability of the skill mix both within and after hours. So what they told us is that our ward nurses told us they felt confident in responding and caring for an adolescent patient who may have mental health problems or for a patient who may experience mental health deterioration. Their skills, however, were mainly learnt on the job. Junior medical staff talked freely about the challenges in detecting the subtle changes, but they had good use of secondary measures such as tracking the use of the patient's PRN medications and monitoring the number of required medical reviews. Like the nurses, they too felt their skills were learnt on the job. The adolescent medicine team also consists of a large multidisciplinary team, all of whom are available to respond to a person's mental state. We have external teams too, such as the Code Grey team, HCL team, and psychiatrists. Our allied health and specialty teams' availability does vary both within and after hours, but this is consistent with other services within our hospital. The introduction of our after hours project team and some additional funding has provided an increase in FTE and extended hours for some of these teams. The next EMT worksheet focuses on the specific skill of recognising the deterioration and what tools do we have in place to support the staff in recognising this deterioration. RCH is a large teaching hospital with variation in skills amongst our workforce. We could sit quite comfortably with this variation, however acknowledge that some variation could possibly lead to poor detection of early warning signs of mental health deterioration and subsequent delayed escalation. We have great tools built within our EMR. However, on the general rules, we do not use a track and trigger chart to document a patient's mental health status. Acknowledging this gap, we've commenced collaborating with other paediatric hospitals and noted the challenges of the paediatric track, what a challenge a paediatric mental health track and trigger chart may bring. With no internationally validated paediatric chart, RCH will move forward towards developing a guideline to bridge this gap. The adolescent ward is a challenging space. Patients are medically unstable with complex physical conditions as well as significant mental health problems that may pose a risk of harm to both themselves and or to others. The next part of the EMT we discussed was relating minimising the harm. The questions we asked was what were our collaborative processes for identifying the risk of harm. Our staff acknowledged that collaboration is something in paediatrics we really do quite well in. We collaborate with patients, family and each other. The adolescent medicine consultants and the RCH mental health team have a strong relationship. They have regular meetings and they provide our families with twice weekly family meetings. Our EMR has various risk assessment and screening tools. However, the nurses thought that the development of a validated screening tool for risk of harm may be beneficial. We next moved on to the process of escalation. The nurses' escalation was consistent with their escalation for physical deterioration. They escalated to their ANUM or to the bedcard team. The doctors too escalated to their consultants, but if the patient had previous HCL involvement, they may directly escalate to the HCL team member. Our consultants' discussion regarding escalation focused on their challenges when they felt their patient needed to be transferred to our mental health ward, with problems experienced particularly over weekends and after hours. RCH was involved in a project by Safer Care Victoria called Hear Me, and this was modelled from Ryan's Rule. This has been put on hold due to COVID, so at the moment we provide consumers with an opportunity to escalate through our Consumer Liaison Officer, and this includes for any clinical concerns. But we acknowledge that this service is not quite the optimal approach. At RCH, we're fortunate to have additional team responses. We have the Hospital Consultative Liaison team available Monday to Friday within hours and on weekends. After hours, we have an on-call psychiatric reg. The discussion around our additional response teams mainly refocused on our HCL referral system. The method of referral was not consistent with other RCH referral systems, and referrals over the weekend and after hours were at risk of being delayed due to stretched resources. The next part of the EMT focused specifically on training. We found the questions the EMT provided on this worksheet provided some repetitive conversation we'd already had by the other worksheets. We believe the main problem associated with our training lies that RCH has not formally evaluated our training needs for our staff, and we need to further develop our organisational matrix.
Optimal decision making relies on information being accessible, contemporary, comprehensive, and able to be interpreted by clinicians. One question the EMT asks here is, what information is available at the point of care? The staff told us our EMR is always available at the point of care, but it can be difficult to access the required information quickly, and it requires a more consistent approach. Our comprehensive behavioural care plans are important, but not all patients have had them completed. Our behavioural communication screening tool is used ad hoc and should form a more proactive approach. All mental health patients coming through our emergency department have a mental health risk assessment. Sometimes staff will have to ring HCL to get it completed should a deterioration in a person's mental state occur. Whilst all code greys are recorded in our incident management system, recommendations from the code grey team may not be consistently recorded or shared with the relevant teams. The environment in which healthcare is delivered can support strategies to reduce harm related to deterioration in a person's mental state. Noise levels, brightness, freedom to move about, access or natural light. One of the questions the EMT asks here is the environment in your local setting likely to cause additional stress to people managing their mental health? The nursing staff told us they have access to gardens, single rooms, social spaces, which are all positive environmental factors. One issue mentioned regarding the environment was in high-risk patients in the adolescent setting, the need to have locked or one-way doors would be beneficial. This has been learned from our mental health board. Another issue discussed was the code greys are highly visible and audible to other patients and family within the ward. This may trigger other patients. This phase considers how we are evaluating the overall effectiveness of our systems for recognising and responding to deterioration in a person's mental state. One of the questions here from the EMT asks, can we tell if our processes are effective? At the time of conducting this piece of work with the EMT, we believed it would form part of evaluating how effective our processes are when recognising and responding to deterioration in a person's mental state. The staff did talk about having code grey data, but what do we do with it and how can we learn? We have since implemented evaluation of some of our services. Other areas, how we evaluate our processes is through the quality department. We receive incidences from the clinical areas, we receive feedback from consumers and their families, and hear a word of mouth feedback from our staff. As facilitators, we didn't really spend enough time asking staff about how the processes are evaluated. So in summary, we are in our infancy of our improvement plan. Since February this year, we have focused on some quick wins. We've established a mental wellbeing committee. We've improved our referral process to our hospital consultation liaison. We're job sharing between our adolescent and mental health wards. We've also created a preventability and predictability template to evaluate our Code Grey system. We are trialling a single mental health screening question to be asked on admission, aiming to validate it against the SDQ. Our nursing innovation team is rebuilding the documentation process within our mental health board. The exciting news for the campus is we've just received funding to support a 5-year mental health strategic plan. The problems and gaps that we have identified will formulate aspects of this plan. So in summarising, the escalation mapping tool certainly assisted us in this process. We couldn't have done it without it. We're not mental health clinicians, so the questions at the top of each template, not the tick boxes, helped us to drive discussion within the groups. We could relate the proposed question back to the national standard through the hyperlinks on the tool, giving us confidence we understood where any gaps existed. Initially, it was our understanding that once we had populated the template with the evidence, then it would auto-populate the last section with gaps we needed to address. But we discovered this was not the case. We then designed an additional template and manually revised what the problems and gaps were and collated them on a final slide. If the EMT was to be reviewed, then we would encourage an additional template that highlights the gaps.
Code Grey, East Building, lower ground floor, ED, E-bar room. Code Grey, East Building, lower ground floor, ED, E-bar room.
Very timely. On that note, we'd like to thank you for allowing us time to share our experiences, and I'm happy to hand back to Andrew at this stage. Thank you.
Just sitting there with a microphone, didn't you? Doing the Code Grey. Thank you so much for that presentation. Thank you for the honesty. I think sharing some of the things that you found, you know, not all of it. We don't always want to advertise, you know, what's happening and where there are gaps, but it's very, very helpful to understand. And, you know, I've seen your presentation before at Children's Health Care Network. So it's really great to see what you've instituted since. A little terrifying that you call what you've done the infancy of your improvement process, because you seem to have done a lot. And I think, you know, down the track, it will be interesting to see if that stuff can be shared. But, you know, because those templates and things and trialing things, that's the kind of knowledge that obviously we all need to know about. And thank you as well for the comments about the EMT, and we definitely will take those on board and try to fix those things at the review. So we might move on to our next speaker before we have some time to take questions. John Foster is a mental health nurse and psychotherapist. He's got 30 years experience working and teaching in public and mental health and acute health services, with a particular focus in clinical liaison psychiatry, working at St Vincent's Hospital in Melbourne. And John has a strong interest in increasing nurses' skills and capacity to recognise and respond to deterioration in a person's mental health in the acute setting. And he's recently completed Masters of Advanced Nursing Practice researching this topic. So John has kindly agreed to talk with us about a tool that he has been developing. So thank you very much, John.
Thanks, Andrew. And I'll just check with Angela that everyone can see my screen.
Yeah, we can see your screen. Thanks, John.
Thanks. Yeah, look, thanks very much for the opportunity. It's yeah, great to be able to talk a little bit of our work, although I do pick up on the notion of infancy, even though we've been doing this for a while. It still feels like it's infancy. I'm going to talk to you about our experience of going through the journey of looking at a framework of how we set something up for responding to deterioration in a person's mental health, and just some of the project development and the research we put around that, around nurses' experience of using a chart. First, I work in consultation liaison psychiatry. St V's Melbourne is 360 beds, and we've got effectively 5 EFT of psychiatry and 1.6 of mental health nurse that provide the mental health support in the general hospital. I'd like to acknowledge, firstly, you never do these things alone, particularly the Inclusive Health Program, which is a national program sponsored by St Vincent's Hospital Australia, and they provided funding for backfill to be able to do some of this work. And then I had a project team of a few people, and also my co-authors in research, Lisa and Kathy. And without them, you know, I think you, as people would know, you can't do this sort of stuff on your own. Particularly like to thank the nurses who participated in our trials. As Andrew already described, this is where we all sort of probably started, and that notion of a slippery slope, I think, is quite relevant. And particularly when you think that in Australia there's a 20% incidence of hospital inpatients with comorbid mental health disorder, and that we really only have mechanisms to identify and then respond to physical deterioration. So again, look, Andrew did go some of this in his introduction, but there aren't particularly specific validated tools. There are some measures, and they've been validated, which I've identified there. And the other thing that stands out is that there's no clear indicators for deterioration. We do have psychiatric indicators, and particularly around mental state examinations, but nothing else from a generalist perspective or population. And in some ways that guided our development. So like everyone else, we started with the challenge of developing a framework with sort of nothing, and just some pretty good research and reference material, particularly that came out from the Commission. We played around with the psychiatric risk features, and what we discovered was that we were trying to introduce a capability into generalist colleagues to be able to do mental state assessment and predict deterioration, when in fact that comes from extensive learning and experience and some expertise developing over time. So with that in mind, we moved away from the sort of psychiatric languaging and literacy, and looked at something that might be a little bit more common to generalist colleagues and people in general, and came up with the notion of signs of distress. Generally, we all know them, we're familiar with them, they're part of the human condition. But our hypothesis was that this could actually be a preventative structural thing to put in place, is that when we started to rate people's distress, that might give us an escalation pathway to respond before it gets to acute deterioration. Because generally, the path of referral to our work would have been someone feeling like someone's not quite right, or the behaviour had already been revealed. So what we did was decide actually to put this into a chart, despite the suggestion that charts may not work, but in the sort of idea back then of how we might actually provide a guide for nursing staff to identify the distress, and then do an escalation pathway around it. After we set up and developed the chart, we then did a qualitative study and really did focus groups and a thematic analysis of the nurses' experience of using the chart to really inform us and guide us for further development. The study design, we completed a literature review, and really started with a quality project to develop the observation chart. We did a trial in 3 wards just to get an idea of the structure and the format of the chart. And then we conducted a further 3 trials of a month each in additional wards, which was where the focus groups and thematic analysis occurred. Just to give you an idea of what infancy looks like, this is when we started, and you can see there that's a good body of 2 years' work to get there. So I think probably everyone else would have similar experiences. So we used the idea of modelling on the vital signs of observation and response chart, but using signs of distress, so that we still went with a trigger and track and trigger chart format and similar escalation progress. The idea being that the nurses on the wards and medical staff, for that fact, are familiar with that framework. So that was what informed us to try that out. These were the distress symptoms that we came up with. And as you can look down there, they're all pretty evident signs that we see in people. And I often get a question as, well, what's bizarre behaviour? And I think when you start to go, you know, like someone just suddenly turns around and just does this, or they just shut their eyes or grimace, we start to move into that realm. We then put it into a similar observation and response chart, except with the measurement, we used the nurses' subjective rating. We know that nurses have an intuition of things not being quite right, and looked at low, severe and moderate rating. And what we did with that was then put it into the escalation pathway, so that a low rating, the nurse could engage with the patient and check out what was going on. But a medium rating and severe rating would require discussions with the nurse in charge and contact with the home medical team. Now, a referral to a specialty service could occur at any time of that, but certainly it was bringing it into awareness and guiding nursing staff and medical staff for a response. The framework was again on the chart like this, and it wasn't just about to psychiatry, it was actually looking at mental health in generally. So referrals could go to geriatric medicine, pain medicine, addiction medicine, palliative care services, social work, pastoral care, at anywhere along that continuum. Once we did that, we had a look at the thematic analysis, and these were the emergent themes that came up in the work. And I think it really captured it for us. I'll talk a little bit more in detail for each of them, but some nice quotes that sort of show the nurses' experiences. We did 9 focus groups. There was a total of 35 nurses, and they range from enrolled nurses, graduate nurses, up to unit managers and nurses with over 10 years nursing experience. Interestingly, none of the participants had any prior formal mental health training, apart from the training we provided in the trials. In the context of its clinical relevance, certainly staff found it useful. Conversely, they also thought, you know, there was a level of an expertise that they were already good at doing assessments and didn't need a chart. And, you know, it sort of adds that sort of information around, well, maybe charts won't work. And then there was a question about how we rate severity, which I think relates more back to the nurse's expertise. Certainly the idea of designing the chart was to make it an easy chart to use, and I think we captured that. The significant thing that against the easy chart to use was that there was also another trial of charts in the hospital at the same time, and nursing staff had a similar experience of additional paperwork. I noticed in the literature that similar experiences were identified when they introduced the observation and response chart. The other thing was that actually nurses are capable, and some nurses were already quite equipped to manage it. And there were certainly some thoughts that maybe graduates or nurses with less clinical experience could benefit from this sort of a guide. Again, this was reflected in previous studies of the observation response chart. I certainly have to agree that it wasn't for all patients. And these quotes, I think, captured that, particularly sort of day surgery, overnight surgery, or patients that actually don't have any distress, because sometimes we don't get patients who have distress. And the other theme that came up was getting the doctors on board. Really what came out of the study was that nurses really would like to work collaboratively with the doctors in identifying and responding to deterioration. So just in sort of a summary, that the clinical relevance was influenced by. And what else the study showed was that really, I mean, and it's not surprising, nurses are a cornerstone in patient care. They've got the most immediate and direct relationship with our patients. There's quite clear deficit in mental health competency. And I think that's also what informed us to look at signs of distress. Whilst it's a new practice using signs of distress, it also does exist in oncology and aged care settings, but that we do still hold a notion that distress symptoms may be more successful than trying to adapt psychiatric or psychological based tools. So in reflection on our study and our work, I think that signs of distress still may be useful exploring, definitely within the capability of acute health nurses, staff. They do have a level of simplicity, and I think the significance in trying to introduce a framework that isn't complex is important. And at the moment, we still don't have any validated tools that can effectively predict deterioration. Our challenges really was, and a lot of the stuff that I experienced was holding the dissonance that exists between a hospital project where there's a wish to respond to, say, national safety standards or just quality development, and then also the process required for research, because they don't sort of match up from a time frame, and there's usually different groups responsible for each. So where we're at now is looking at refining the chart, and I think there was something that Andrew was referring to, and that is about working with the patient. We do feel that the distress could actually inform a way to support and provide an escalation framework. There might be usefulness in looking at those signs of clusters that have been identified as maybe the precursor to implementing and using a chart to monitor a person's distress for deterioration, so that you could then become a little bit more specific around certain patients. Certainly keen to put this into a paper and then explore the opportunity to further research either this tool or a refinement of the tool. The key bit that I'd be interested in now is looking at the interrelatability of signs of distress in specific patients, and I think that would be the next step that we would want to look to going away to validate. And I think that might sort of be around the time frame that you need, Andrew.
Okay, thank you very, very much, John. I am sure that, as with your previous presentations, will have generated enormous interest among people, and it's great. It's just great that you're still working on the chart, and it may in fact answer for a huge number of services. So that's really good. I really liked as well some of the tensions that you highlighted. And certainly one of them over the years is that holding in place that nurses are capable, and on the other hand that they don't have the formal training, and of course pulling it back to the idea that many of these things are part of the human condition, and so people have skills from elsewhere in their life that they don't necessarily have clinically. And yes, we're already getting requests that the work be shared, and I think John is going to go through the process with his colleagues of writing it up, and certainly we will make it available as soon as anything is published. We'll flag it with anybody who's participated today. I wondered if those photographs were the nurses themselves trialing in your trial, but no, it turns out they weren't. So thank you. And we do have a time for a few questions. So some of those relate to, but how do I apply this in my specific setting? And so I think those are for conversations down the track. I think the point that we're discussing today is, I can't read them. Yeah.
Isn't mental health covered in every nursing degree and compulsory now in enrolled nursing courses? Is it a matter of making this more of a requirement in their general nursing standards? And that was from Sandra.
Okay, thank you, Sandra. So that's probably to us more than to the speakers, but I think, I can't remember, somebody might be able to tell me, but I think the average age of nurses is clocked over 45. And so, yes, while curricula now do have that formalised training, it's not necessarily been embedded into the training for all of the nurses who are currently working. So we will see that shift. Anecdotally, I've heard that there's a really noticeable shift in people's preparedness around when a person discloses thoughts of suicide and self-harm, that junior clinicians have greater preparedness perhaps than they once would have had. So that's a really encouraging development.
There's another question that just said, sorry, I'll just get it up.
While you're doing that, I just want to make another comment that arose out of John's paper. Of course, when a deterioration in a person's mental state has been detected or identified or reported by the person themselves, there can be so many different reasons why this has occurred, and therefore so many different directions in which the response will go. And so, I mean, the classic was always that 80% of calls to CL teams were in fact for delirium, which by now should be part of all clinicians' capacity to recognise and start treatment for. But yeah, there can be so many different reasons and so many specialists that can be involved. And so the recognition is just the first step. Having a stepped and nuanced escalation pathway so that people get to the right care is a big part of what a local process needs to be.
There's a question that says, do you think this tool, and I think this is John specifically, will be able to be adapted to outpatient services?
Yeah, I think so. I mean, I think that it's really because of the simplicity in using something that's accessible for staff around distress. I've had some queries around the aged care setting, both residential and psychiatry, but also addiction medicine. And I think it's because in all those settings, it's where distress is quite obvious. So I think it would be, you know, if you can think about a patient coming in or a person coming into outpatient setting, that where you pick up on their signs of distress that might actually get a response to where they can get some further support from. I think there's scope for the concept to be adapted. And, you know, I think Andrew's already described how much we learn and grow, and the observation response chart process would probably be a good model to see how that developed.
So we're going to finish up in a minute, and I want to put a plug in for the speakers we have next week, because we've designed the two webinars to complement each other. And so I would really encourage people, if you do have capacity, to participate next week. I just would like to offer the speakers, if in delivering their talks, are there any last minute things you want to tell the audience?
Emily, I think you're on mute.
Oh, sorry, is that directed to us, Andrew? Yes.
Yeah.
No, I don't think so. I mean, we just think it was beneficial. It's based on the EMT, and we're now just thinking about do we trial it in another area, or are the problems and the gaps identified going to be universal throughout the hospital? So we're just at that stage now.
And I'd just like to say thanks, Andrew, and be happy to, take responses from anyone who's been participating today.
And of course, on behalf of our participants, I assure you I will haunt these people. I will chase them up, and as stuff gets further along the evaluation, it's just so valuable for us to be able to share it. So huge thanks to Emily, to Jackie and to John, and really look forward to seeing people next week when Casey and Eileen and Heather join us. So please come back. Thank you very much.
Thank you.
And turn me off.